Okay. Sanu, I think your microphone may have been turned off. Hello, everyone. Good evening, and welcome to the Tendinopathy webinar from the AAHS. This evening, we have an exciting program. My name is Miguel Perola Cruz. I'm at Texas Tech University in El Paso, Texas, and I'm a hand surgeon, upper extremity surgeon. Okay, can we go to the next slide? And joining us on our faculty, we have Don, a gentleman who does not need any introduction. He's well known for his surgery. He's visiting us from St. John, Canada, from the Houston University, professor of surgery there. And has really written and educated us on a lot type of surgery, which is amazing. He's going to talk to us about trigger fingers. Next slide. We also have Stephen Niedermeyer. He's joining us from step 3. He's joining us from Arlington, Texas. This is actually he's with the TMI Sports Medicine, upper extremity surgeon, and he's going to be talking to us about the Quervain syndrome. We also have Rena Fatt from Brown University, associate professor at the School of Warren Albert School of Medicine. She's chief of hand surgery, plastic surgeon, and she's going to speak to us about ECU tenosynovitis. And we have Aziz from the Mayo Clinic. He's an associate professor there, hand surgeon, consultant in Jacksonville, Florida, and he's going to speak to us about lateral epicondylitis. Okay, with that and those introductions, Mary Barnes. I'm sorry, Mary. She's an occupational therapist. She's in Franklin, Tennessee, and very knowledgeable. Was former chair of the Tennessee Board of Occupational Physical Medicine, and really educates a lot of the hand therapists and physicians about therapy as it relates to the upper extremity. She's going to speak to us about rehabilitation of these tendinopathies. Okay. With that said, let's go ahead and get the show going. And we have our first batter up, which is Don. Can you hear us, Don? I think you're muted, Don.
Yeah, somebody is, hang on a sec.
Can they mute the microphones in the background that is not being used? Okay.
There we go. Can you see my slides there, Miguel?
Yes.
Fantastic. So I'm going to talk about trigger fingers. It's something that you all know a lot about. So I'm going to try to share with you some things that I've learned over the years that you might not know. So one thing you might not know is a nice way to do trigger thumbs is prone, especially when they're awake. It's just not a problem. And I don't do anybody with sedation. I don't offer it because it's just not what I do. I'm going to show you how to inject it so it doesn't hurt, because a lot of people still hurt people with Wallant. And so the first thing is that you start with a 30 gauge needle and really pinch the skin and hold the pinch until they tell you the pain is all gone. So here we go.
You see this though. That's okay. So I'm going to count to 3. When I hit 3, I'm going to put a little needle poke. So try not to move. When I get to 2, I want you to take a nice deep breath. So, and I'm going to pinch 2. So 1, 2, 3. Very good.
Now hold that pinch. Don't let it go. It's sensory noise.
Please tell me when the stem is all gone. Yeah. Okay. How bad was the sting?
Not bad at all, really. 0 to 10. 1. Didn't hurt at all, really.
Great.
I'm on issue.
Very good. Thank you.
So digital blocks can be sore, but if you really pinch the skin into the needle, instead of pushing the needle into the skin, it hurts less. And also never inject in the sheath. I've been injected in the sheath 4 times, 3 times on purpose, 1 time by accident. It really hurts. It explodes. It just really stinks. And also, don't do it over 10 seconds. Like, do it over a minute at least. And I like to put in, 4 or 5 cc's, and then let her go to the bathroom, do a few other patients, and then by the time you're doing it, things are looking pretty good. So here's the same case. I love these vein retractors. I'm going to show you how I put them in a minute. That seems ridiculous, but it really makes it very easy if you put it in properly. And then you want to make sure that you go distally enough. She had some synovitis there that was a little adherent that I had to let go. And also, I ended up doing just a little bit of reflection of the flexor tendon synovium, which goes proximal to the pulley. So that's looking pretty good, but she had a little synovitis proximal to it. So I do that. I never take out superficialis with triggers. Don't know why people feel the need to do that. And it's not very aggressive stuff. I just open it up and that's it. And then I like to close with buried 5-0 monocryl sutures. These are dermal sutures, not transcutaneous. They're dermal, buried sutures. The knot is buried, so there's no stitches to take out. They deep to superficial, superficial to deep. There's no fat in these bites. You got to get your medical students to make sure they don't wrap the needle around a digital nerve. And they get in the shower the next day, wear a Hollywood bandage for a couple of days, pain-guided healing. And that's pretty much it. So the trick to doing trigger fingers is you put your scissors or a blunt object like hemostat, touch the sheath, one big spread and hold. One big spread and hold, not 15 spreads. You don't need 15, just one. And then as soon as you've done that, you've created an optical space. So you touch the sheath with the vein retractor and push down, don't pull sideways. Touch the sheath with the vein retractor, push down, don't pull sideways. And there you are. It's like a 4-move checkmate. Cut, spread, down, down, and you're good to go. So now, when I started my practice 40 years ago, everybody got a treatment, okay? They either got steroid or surgery, but they all got a treatment. Now I feel a need to educate rather than a need to treat, because you know what? A lot of patients just don't need any treatment at all for trigger finger. They just need education. So I'm going to show you 4 minutes of a 7-minute consultation. If you want the whole consultation, just take the barcode and it'll download the whole consultation. But this is after I've explained what a trigger finger is and after I've explained the steroid and surgery options. Now I talk to them about the doing nothing option. Now, this is not appropriate with a fixed flexion trigger finger, which you don't see very often, but this is the do nothing option. Here it is.
Option 3, which is doing nothing. Now, doing nothing is a reasonable option if this doesn't bother you that much. So let me start by saying that I had a trigger finger in this finger for 1.5 years, and it went away all by itself with no treatment at all. Now, it didn't bother me that much, though, to be fair. It would get stuck in the morning, and usually by afternoon, it was only a little bit annoying, and by evening, it was often, I could barely feel it. But I'd wake up in the morning, I'd be stuck again. I'd be snapping out for the morning. It didn't stop me from operating. I'm right-handed, it was on my left hand. And really, it was more annoying than it was a problem for me. I could still do just about everything I wanted to do. After 1.5 years, it went away all by itself. Then I got one of my left long finger, and it went away all by itself after about 6 months. We did a study of over 300 patients in this office a few years ago. And 150 patients, or half of the patients, got better all by themselves with no treatment whatsoever, no steroid, no surgery, no nothing, by 8 months after I saw them in consultation. So my story is not unique. It's a common thing. It comes and goes. Now, a lot of people come in here not because they want an operation. They come in here because they got a problem and they don't want to screw up their hand. If you choose to live with this trigger finger, you're not going to screw up your hand. And chances are very good that if you wait long enough, someday it'll go away. I have seen them last as long as 8 years, really stuck like yours, and then go away.
You got a
So-
guarantee you're 8 years.
So, well, you know, that's,
So that's the story. My first clue that a lot of patients don't need treatment. When I was a resident in plastic surgery, one of my jobs on weekends in my spare time was to book patients for trigger fingers and carpal tunnels. And I'll tell you, booking triggers was a pain in the patootie because I'd call so many of them. Oh, that's better. Oh, that's gone. Oh, I haven't felt that for a long time. And I'm thinking, wait a minute, why are we operating on these things? And this is the paper that we published in 2017 that showed that there's a 50% chance of spontaneous resolution by zero treatment by 8 months after I see them in consultation. So that's why after I explain to them what a trigger finger is, I love to ask, how much does this bother you? Because a lot of people will tell you, you know what, it doesn't bother me very much at all, which is something I never even thought of asking in the first 10 years of my practice. So a word about steroids. Full disclosure, I've never had a steroid shot in my finger, but I have had lidocaine and epinephrine lots of times. And I've had at least 10 patients tell me in my lifetime, I give them a steroid shot, they don't get better, they come back, I end up operating on them. And then they say, why the hell did you bother with the steroid shot? It hurt more than the surgery shot, and it didn't work. Why didn't we go straight to surgery, Dr. Lalonde? And so 3 times in my life, I stopped using steroids and I started using steroids because of the evidence. And then I stopped using steroids and then I went back because of the evidence. But I'm not greatly supportive of steroid shots. Most people who get better with steroids get better with nothing. So I'm going to stop there, and thanks for the opportunity to share my thoughts. You're muted, Miguel.
Well, that was great discussion, and you always give us pearls when you give your talks. So I always love listening to your talks. And one thing I failed to mention is that we should, if you have any questions, you can put it into the chat, and if we have some time left over, we'll try to get to some of the questions. So that was excellent. And thank you very much. So let's move on to our next speaker. You have it?
Yes.
Steve?
Can you guys
Yeah.
hear me okay?
Yes.
All
Doing
right.
well.
And you're seeing my presentation, not my cheat screen? Yes?
Yes.
All right.
You got-
Perfect. Thank you, Dr. Perella Cruz. Thank you for the opportunity to give this talk. Hopefully a lot of this will be things you know, but I try to add some newer things I learned in my review in preparation for this talk. So don't make this the talk you get up and take a bathroom break for. We'll be talking about dequervains or radial styloid tenosynovitis. These are my disclosures. A little bit about Dr. Fritz dequervain, the eponym, the namesake of this condition. He's a Swiss surgeon, did most of his practice in Basel, Switzerland, which I was fortunate enough to visit this year. But he's not just famous for dequervain's tenosynovitis. He's also the eponym for a thyroiditis that he helped discover and publish in the literature. He was the recipient of numerous awards and distinctions and the author of hundreds of book chapters and manuscripts. And in my preparation for this, I learned a lot more about Dr. dequervain from this article by Dr. Chung. And so if you are interested in learning more about Dr. dequervain, check out that article. The epidemiology, as we typically see it, is more common in women than in men and more common in middle-aged individuals. And the causes are typically overuse. We see this a lot in our postpartum mothers and fathers, as well as grandparents taking care of new grandbabies. And then it can be also be post-traumatic. And so we typically have seen and described this as quote unquote mommy thumb due to lifting children, awkwardly holding babies, as the picture in the bottom demonstrates. But as technology has advanced, I've seen more of kind of these pathologies. You know, our pickleballers who haven't fallen down and broken their wrists yet, they'll come in with dequervains. Texter's thumb has been a new term thrown around for this condition, and then gaming has also resulted in quite a lot of younger folks presenting with de Quervain's tenosynovitis. Now, what is this condition? It is located in the first dorsal compartment, with the abductor pollicis longus being the most volar and radial of the two structures, with multiple slips, and then just dorsal and ulnar to it is the extensor pollicis brevis. Now, this first dorsal compartment is also implicated in intersection syndrome, as these muscle bellies do travel distally and radially, and then the myotendinous junction kind of takes a radial turn before the tendinous attachments at the base of the thumb metacarpal and the phalanges. The provocative physical examination, eponyms, Finkelstein and Eickhoff, much like Ace Ventura, these are often confused with one another, but the proper Finkelstein maneuver is grasping the thumb and forcibly abducting that hand ulnarward, whereas the Eickhoff is having the patient grasp their thumb, relax the wrist, and then ulnarly deviate from there. And then Brunelli has described recently a new test for de Quervain's. Should your Finkelstein and Eickhoff continue to come back normal, you can add this third test into your algorithm, where you maintain the wrist in radial deviation and then forcibly abduct the thumb, eliciting pain over the radial styloid. Differential diagnosis, basal thumb joint arthrosis can often be differentiated from radial styloid tenosynovitis by the area of tenderness, typically thumb CMC tenderness, more distal, whereas the tenderness for de Quervain's is more proximal, located over the radial styloid. But I've had patients with rip-roaring de Quervain's or basal thumb joint arthrosis flare-ups where they're kind of painful all over the radial side of that thumb and wrist, and can be a little bit more difficult to elicit diagnoses between the two. And sometimes these diagnoses do come in conjunction with one another. And then aforementioned the intersection syndrome, because that does implicate the first dorsal compartment as well. But again, the area of tenderness is different, a little bit more proximal over the dorsal distal forearm. And then provocative maneuvers for Finkelstein and Eickhoff and Brunelli typically won't elicit discomfort in intersection syndrome. First line of treatments, typically patients have tried some of these before coming to the clinic. Over-the-counter anti-inflammatories, your Tylenols, ibuprofens, avoidance of activities, and then coming in with either wrist bracing or thumb spike immobilization. I always feel bad for the patients who have just immobilized the wrist and not immobilized the thumb for 3 months. And I'm like, oh, you went through all that immobilization and really the thumb needed to be included. But then I typically do offer patients a first dorsal compartment steroid injection as first line when they come into the office. And especially ultrasound guided. There's good studies that have shown that ultrasound guided injections into the first dorsal compartment are more reliable at assuaging pain with de Quervain's tenosynovitis, as opposed to going in blind, especially for those patients who have a little bit thicker of a wrist and that first dorsal compartment isn't as palpable and those tendons aren't as visible. And then after they failed, I typically give patients 2 shots, literally and figuratively, at an injection before moving on to first dorsal compartment release. But this video represents my technique, going with a longitudinal incision. I know Dr. Jane, when I was training at Ohio State, loved the chevron incision. But getting down through that skin and subcutaneous fat and identifying those superficial branches of the radial nerve, as you see there, and retracting them out of the way. I always counsel patients before this surgery on superficial branch of the radial nerve anesthesia after the procedure. Most patients don't have that, but I mention it for the patients that come back and do, so that way they're not surprised. Once I've taken the vein and the nerve out of the way with either Ragnells, or if it's a little bit deeper, a pair of dull Senrakes, you still want to stay on the dorsal lip of that first dorsal compartment, and you want to incise what I typically say is at the 10% line dorsal of that sheath, because you don't want post-operative volar dislocation of those first dorsal compartment tendons. If you incise that sheath too far volar, the patient will flex down and you can get dislocation of those tendons volarly. And then the other thing to consider, and I typically tell patients this too while I'm doing the procedure, is most patients who need this procedure have that separate subsheath within the first dorsal compartment. So you incise that dorsal lip of the sheath, and all you see is EPB. You have to dissect proximally or distally, whichever you're more comfortable with, to identify the APL, and you'll see that separate subsheath within the first dorsal compartment. And to me, that just means that whenever you were putting the steroid in for the steroid injections, it was getting into one subsheath and not the other, and incompletely treating. And these patients come back typically painful, requiring a procedure. And so when you do the procedure and you see that subsheath, there's kind of a fibroosseous ridge through there, and you want to excise that as well to help prevent recurrence postoperatively. Now, again, decorvains, it's something we've been treating for decades, kind of the same way, but where are we going in the future? Dr. Lalonde has done a wonderful job introducing the world to Wallant surgery, and just like he stated with trigger finger, I rarely do these procedures with any sort of sedation. Wide awake has become my standard of care, whether in office or in a procedure room at my ASC or hospital. But then are there some minimally invasive techniques on the horizon? Some ultrasound guided. We know ultrasound guided carpal tunnel and trigger finger has been a great addition to practices across the country. Is this something we can employ in the treatment of decorvains as well? Or some endoscopic techniques as those endoscopes become smaller and smaller and smaller? Is this something we can utilize in the treatment of radial styloid tenosynovitis as well? Again, thank you, AAHS. Thank you, Dr. Perella Cruz and Dr. Jane, for the opportunity, and I'll take some questions.
That was fantastic, Steve. Thank you very much. We probably entertain one or two quick questions for two talks that just occurred. Does anyone have any questions they would like to ask?
I have a comment to make, if I could. It was a great talk.
Okay.
But one thing that I like to do for decurves is what's called the tree sign. I don't know if you can see myself.
Yeah, we can see you.
Okay, so patients come in and I say, where does it hurt? And they show me a forest. They show me this huge area, right? And I say,
Yeah.
no, I don't want to see a forest. I want to see a tree. Show me the one place with the tip of your fingernail that hurts the most. And when people have decurve, they point right to the end of decurve's canal every freaking time. If they have decurves, they have a positive tree sign. So just try it. You might like it.
Absolutely. I'll add it to my talk, and I'll add it to my next exam. Thank you.
Yeah, you're welcome.
It's interesting that Bernal sign that you referred to. I used to call it the hitchhiker sign. So it's okay. Any other questions? Anything else? Okay. Well, let's move on to our next talk. Who do we have up?
Is that me, Miguel? Rena?
Okay, Rena. Okay.
I think so. Okay, I'm going to share my screen.
She's going to speak to us about ECU tendonitis.
Alrighty. Hi, I'm Rena Bahat from Brown. I'm with the Department of Plastic Surgery. I'm going to talk to you about extensor carpi ulnaris, tenosynovitis, and subluxation. I have no disclosures. So any talk regarding ECU tendonitis and instability requires a conversation about the anatomy and the pathology. These muscles start at the lateral condyle, and then they insert in the base of the fifth metacarpal. It's important to understand, oh my, this is not moving forward. It's important to understand the anatomy of the retinaculum and the subsheath in this area because they're separate anatomic areas. So the ECU goes through the sixth extensor compartment at the distal ulna. Within that compartment, there's a fibroosseous subsheath that's very important for stabilizing the ECU in its sheath and not snapping or subluxing volarly and ulnarly. And then the ECU tendon obviously is in that space, and then the ulnar groove there's always a question whether the ulnar groove is really important for stabilization of the ECU. The ECU takes an angular path across the forearm, especially when the forearm is supinated and the wrist is flexed and the hand is ulnarly deviated. The retinaculum doesn't actually insert on the ulnar aspect of the ulna, the subsheath does, and it creates kind of a checkpoint for the ECU to not sublux and fall off the ulna ulnarly and volarly. And that's an important point because it's important to understand for our reconstructions. The ECU subsheath is the main resistor to ulnar subluxation. So when we talk about the etiology and pathology of tendonitis of the ECU and subluxation, we often think of racket sports and stick sports like ice hockey, sports that cause a lot of form rotation and wrist motion as precipitating causes, but a forceful impact like a motor vehicle accident or a bad fall can cause it as well. Additionally, changes to the fibrosseous sheath from underlying bony pathology can predispose you to ECU tendonitis or subluxation. Repetitive stress on the subsheath, especially in wrist supination and forearm supination and wrist flexion, can predispose to subsheath attenuation or subperiosteal elevation with subsequent subluxation of the tendon. This can occur over time or it can occur after a specific injury. You can also see this in rheumatoid patients with cupa ulnae, but I'm not going to focus on that for this talk. These patients will often come to you with dorsal ulnar sided wrist pain, in the region of the sixth extensor compartment, especially over the distal ulna, but it may be along the whole course of the ECU. There may be focal swelling there. Many times if they have instability, they'll describe a feeling of snapping with forearm rotation, especially with supination. You may see subluxation of the tendon that's overt on supination. They might have pain with resisted wrist extension, especially in ulnar deviation, and they'll probably be tender over the ECU. There are some provocative maneuvers that might be a little bit more focused, and the ECU synergy test is often quoted as one to use. And in this test, moving on, you maintain the elbow in 90 degrees of flexion and supinate the forearm. And then with one hand, you hold the patient's thumb and middle finger, and with the other hand, you put your finger on the ECU tendon, and you have them resist with their thumb, and that may elicit pain or cause bowstring of the tendon, or it may even cause instability, especially if you passively rotate their forearm. You can also just examine them passively in forearm supination and pronation. This is a video Dr. Hammert sent me, and you can see this patient's ECU tendon subluxing with supination and pronation. I often will get an X-ray to rule out bony pathology, and then at that point, I'll decide whether or not to get an MRI or a dynamic ultrasound if I think I need it. MRIs help me for eliciting other causes of ulnar-sided pathology, because they may have more than just ECU subsheath pathology. And then ultrasounds, dynamic ultrasounds are a really good tool for me in terms of assessing for dynamic instability if I'm not seeing on exam. This is a patient who had a prior TFCC repair years ago and presented with ulnar-sided wrist pain. And I didn't notice overt subluxation, but if you look at the ECU tendon over here of the distal ulna, you'll see that it's sitting volar and ulnar in the ulnar groove. So it's not quite sitting in the groove anymore. So a sense of instability here. And if you look at the same patient's dynamic ultrasound, you watch the tendon right in the middle of the screen. As she's supinating, you'll see it's in the groove, and then as she supinates, it's subluxing ulnarly. Treatment for these patients, it really depends on what we think is going on. If they have tendonitis, maybe think about immobilizing them for a few weeks. A long arm splinter cast might be the most helpful because it'll control for forearm rotation, keep them in pronation and radial deviation, and perhaps wrist extension. But if they're acutely subluxing, you may want to think about immobilizing them full time for 6 weeks to try to truly treat this. If they're persistently symptomatic or refractory to treatment, or if they have chronic subluxation, perhaps we think about reconstructing them. And in this situation, a lot of times we want to look at the ECU tendon to make sure we don't need to debride it because there may be some attenuation, and then we want to reconstruct the subsheath. So reconstruction depends on what you think is anatomically there or what you find anatomically there, but also your personal preference in terms of subsheath reconstruction. Sometimes we can reconstruct the subsheath with suture anchors if there's a subperiosteal disruption. Retinacular flap is often used, and I'll describe this in a moment. Retinacular grafts can be used. The real question is whether or not we should be deepening the groove, and I think the jury's still out on that. I personally don't do it anymore because I've had problems with causing abrasion of the undersurface of the ECU tendon. So it's not something I personally pursue, but to each their own. And I think that there's some good data in both directions, but I think a lot of the data is kind of pointing towards not possibly needing it. Do not over tighten your repair. You can cause a lot of problems with ECU pathology with over tightening. this is a case that Dr. Hammert sent me, where, sorry, it's advancing too quickly, where the patient had a separation of the subsheath from the underlying ulna, and he exposed the ulna on the volar ulnar aspect and subperiosteally dissected the subsheath that had pulled away and advanced it and inset it with suture anchors. And you can see that here on the top right and the bottom right and the bottom left pictures, what it looks like after the advancement of the subsheath and repair. These patients usually get casted for about 6 weeks with a long arm in forearm pronation and wrist extension. Retinacular flaps can be performed. This is a technique that I've used before, where you harvest a 2 centimeter flap, extending over the third extensor compartment is your distal margin, and you elevate it towards the fifth intercompartmental septum. But you can also do it at the fourth, fifth septum, and you bring it under the ECU tendon, and you wrap it around itself to that intercompartmental septum, and you suture it down with permanent suture. If there is subsheath left behind that you can find and you can elevate on the dorsal radial aspect, you can think about re-advancing that prior to inset of your sling, and create a new gliding layer, another reinforcement for your repair to prevent the ECU from subluxing ulnarly prior to inset of your sling, which is going to wrap around this area. Which form of treatment should we be pursuing for these reconstruction patients? Not sure, because I'm not sure we have evidence that a single technique has been proven better. What should we do about groove deepening? Again, not sure. There have been some MRI studies that looked at ulnar groove depth and radius and curvature, and then whether or not this is associated with patients who have ECU pathology. And there wasn't any significant findings in Chang's study in terms of independently associating ECU pathology and groove depth or lack thereof, or shallow depth. There was an association with ulnar negative variance in this study. Carlson's group looked at a cadaver study and evaluating cadavers who had intact subsheath versus cadavers who had sheath reconstruction, versus cadavers who had sheath reconstruction and groove deepening, and did not find improved stability in the patients with the cadavers, not the patients, with groove deepening. And so, the real question is, do we need to focus on groove deepening, or should we be focusing on mainly the subsheath reattachment? And in conclusion, the anatomy of the subsheath is important in understanding the instability, what causes instability. History and exam will help direct our diagnosis. I do find dynamic ultrasound very helpful, but I might need an MRI to rule out other parts of my differential. There are multiple techniques. I think the jury's out about ulnar groove deepening. And thank you. These are my citations.
Well, thank you very much, Rita. That was very excellent review of ECU. Any questions that we may have? Does anyone have any questions? This is certainly a difficult problem to treat clinically, I would say. I think I like that empty sulcus sign. You can sometimes see it on CT, which is really nice and kind of gives you a little idea. But obviously, with a lot of these tendinopathies, there's a spectrum, and you got to try to identify where your patient falls and what kind of treatment they need. Okay, so let's bring in the next speaker if we have no questions. And we're going to speak on lateral epicondylitis, and we have, who's up? It's Keith Aziz. Keith, ready? Next batter up.
Hey, how's it going? Sorry, let me change this display setting really quickly. All right, great. So I'm Keith Aziz. I'd like to thank you guys all for your time and logging in. I'm coming in from the Mayo Clinic in Florida, home to many professional and aspiring professional and amateurs who think they're professional golfers, which may be why I was tasked with talking about tendinopathies about the elbow. Lateral epicondylitis, as you all know, requires an element of patience for all parties involved. And I will make the distinction and argue that we should probably continue to push to call this epicondylosis in recognition of the fact that I'd say it's less of an inflammatory problem and more of a degenerative problem. I have no pertinent disclosures and going to go over the epidemiology, natural history, review kind of some of the existing conservative options, and discuss some of the newer things that I was less aware of, in training, or maybe weren't around it as much in training. And then we'll open up for questions at the end. This is an incredibly common problem. I can guarantee that at least one person on this webinar has dealt with this because I developed actually lateral epicondylitis. The name tennis elbow is associated with it, but it certainly does not have to occur in patients who play racket sports. It's more common in patients who are 40 to 60 years old, and it tends to affect the right side more, likely because of patterns of hand dominance. Dr. Maury did a series of patients in Olmsted County in Minnesota, and about 16% of patients actually had a work restriction and 4% missed work. So it's important to be aware of from that perspective. Patients are often tender over lateral condyle. They have pain with activation and passive stretch of the radial wrist extensor, specifically the ECRB. In my experience, there's often a change in grip strength when you take the elbow from a flexed position to an extended position, because that extension places the affected muscle on stretch, and there's an element of the pain inhibition to grip, and I think it's a valuable diagnostic tool to utilize. As long as you have more than 8% change going from flexion to extension, it has a high enough sensitivity and specificity to be somewhat reliable. This is an overuse phenomenon, and I think it's appropriate and a very often analogy that's used that relates to fraying of a rope. And that's again why I would kind of opt more for the description of epicondylosis as opposed to itis. Histologically, there's kind of a buzzword, angiofibroblastic dysplasia, and grossly the disease tendon origin really, in my experience, kind of looks like dried glue. This really occurs, I think, because of the anatomy of the ECRB and its origin. It lies immediately deep to the ECRL. So this picture on the bottom left kind of shows cadaver, and reflection of the ECR shows the ECRB. So when you activate those radial wrist extensors, the ECRB becomes dynamically compressed against the lateral epicondyle. People who work in industrial or assembly line type work where they have to do repetitive gripping, especially with the elbow extended, where they're reaching out into a line with the forearm pronated, commonly present with these types of symptoms, though also leisure sports such as tennis, pickleball, and golf can start this process. I actually developed it because of golf, because the lead arm, on the right image on the screen, has the elbow extended and the wrist extensors firing to kind of keep the club in line with the swing. And especially if you go to the driving range, which is more time efficient from the number of balls you can hit per unit time, you're more likely to develop this. The good news is that most patients have resolution of their symptoms with conservative measures, even with a wait and see approach, which is employed as a treatment arm in some of the studies that have been performed. Though I will make the argument that even if you choose this kind of benign neglect technique, the evidence has shown that patients will return to pain-free activities sooner if they engage in some form of either home exercise program, stretching, strengthening, or something of that nature. So although technically speaking, most patients will get better on their own, it's still reasonable and appropriate to kind of help them. And my co-panelist actually did a nice study, Dr. Niedermeyer, looking at upper extremity surgeons and the treatment options that are often employed, with the most common being home exercise program and stretching, as well as non-steroidal anti-inflammatories. When you're talking about the exercise and stretching algorithm or modality, there's a lot of different protocols that are utilized, but in my opinion, there's enough data to support eccentric strengthening for me to recommend it primarily in my practice. And what will sound like a bit of a theme as I describe some of the evidence for lateral condylitis, the studies and protocols are highly variable, and there's a lot of heterogeneity in the available evidence. But this kind of falls into the arm of something that has limited to low risk, and there's enough evidence to support it. So the important thing when educating patients about eccentric strengthening is that really they should be activating the muscle as it's lengthened. So they shouldn't be doing both the concentric and eccentric. So as this photo shows in the top right, they should use the other hand to kind of bring the hand, wrist back up to a position, and then allow that resistance and its gravity once again. For bracing and immobilization, even though Dr. Niedermeyer's study showed the counterforce brace was more commonly used, there's really no data to support one over the other. Both do seem to provide some level of symptomatic relief. Both are also relatively inexpensive, but I would argue that patients find the counterforce brace to be a little bit less restrictive, which, depending on your patient, can either be a good or a bad thing. But I think because of that, they're probably a little bit more compliant with the counterforce brace, and that's kind of demonstrated on that image in the middle. And a simple cock-up wrist orthosis will just, again, rest those radial wrist extensors. For more kind of modalities, both shockwave and laser therapy have studies that are in support, but again, the quality of the evidence in both is not great. And I would say the majority of the studies that I reviewed, of which there are many, there's no difference between either and a placebo. That there are certainly some studies that are in support. When you're looking at more interventional techniques, dry needling is believed to promote angiogenesis and has shown some benefit. Interestingly, I think that's something you have to be sensitive to your region or locale. Here in Florida, only physical therapists can perform dry needling because of the strength of the acupuncturist lobby. Again, there's a lot of heterogeneity in the literature, but there are some meta-analyses that suggest some benefit. One thing that I had not heard of previously was utilization of transdermal nitroglycerin patches, and the belief is that the vasodilation allows for improved perfusion and tendon healing. Meta-analysis will suggest improvement in short and midterm intervals, but the evidence is quite poor in quality. One thing that I think has changed from when I was in training to where I'm in practice now is that corticosteroid injections have really fallen out of my practice algorithm. There were two studies, one was in JAMA and one was in Lancet, and both were pretty well conducted randomized controlled trials that included corticosteroid injections as a part of the arm. This figure on the right, I think, really kind of highlights that although patients have significantly better relief in their pain, for that early, what I would call honeymoon period, they're actually often worse off long term. And this kind of makes sense to me from pathophysiologic perspective when we're talking about the fact that this is really more of like an overuse tendinosis, a poor perfusion problem, and the impaired healing ability of the tendon when it's exposed to corticosteroids. I think one of the things that makes that particular finding of the worst long-term outcomes with corticosteroids a little bit difficult when you're considering all the available evidence is that corticosteroids are often used as a part of one or multiple treatment arms, and that can make the evidence a little bit more confusing. Platelet-rich plasma, or PRP, has generally shown effects that are either no difference compared to placebo to good symptomatic relief. I think one of the things that complicates this is that there's widely different platelet levels in the PRP preparations, and that makes it a little bit harder to compare in an apples to apples fashion. There was a pretty well done meta-analysis that actually tracked the platelet levels, and there may be some potential future stronger evidence that supports it, but there is always the element of the fact that insurance companies often do not cover this, and because of that, in my personal practice, it's not a big part of what I do. Um, uh, Sometimes I feel like Botox is the hammer for which people continue to search for nails for. And the theory here is that by causing paralysis, the radial wrist extensors, you'd cause some relative rest and allow the tendon to heal. Most studies show either no difference or actually inferior pain relief and diminished grip strength. So I cannot say that based on my review of the available literature that I would recommend it. And then prolotherapy, is proposed to induce a local inflammatory healing type response, but again, there's not really strong evidence to support it. I debated spending not much time discussing surgical intervention as an option because, in my opinion, it has a pretty limited role in this pathology. Again, most patients get better with conservative measures, but I think it's important to discuss. The traditional options include open debridement, which was first described in 1979, where the diseased portion of the ECRB tendon origin is debrided, and then the lateral epicondyle is decorticated to assist with angiogenesis and healing of that tendon origin. Earlier series were quite promising, with some saying up to 97% of people had some relief. But a recent study, comparing this procedure to a sham procedure, kind of called things into question when the sham procedure was doing better, even though not statistically significantly better, but generally speaking, better than surgery. At later time points. Arthroscopic debridement. is another option with the added benefit of being able to thoroughly assess for intra-articular pathology, which can be a bit of a confounder for lateral elbow pain. As someone who works with residents, I think the educational benefit of this is not lost in me, but it also does have some risk if you're not experienced or used to doing arthroscopy. There is some evidence to suggest there's not really a significant difference between this and open releases. There was one study that did suggest a benefit, but the quick dash improvement was below the MCID values. Percutaneously release, interestingly enough, was described before arthroscopic release, and newer techniques involve ultrasound guidance. But really, there's only one series that directly compares open arthroscopic and percutaneous release, all with the same surgeon performing. There's not really great comparisons between outside of that series, that open or arthroscopic techniques. There are these newer techniques and procedures that have been published on. I think they're interesting to pay attention to. One is blood flow restriction training. Essentially, a blood pressure cuff is elevated on the ipsilateral extremity, and then patients do a low load resistance training. The theory is that this relative ischemic state or challenge state will induce some angiogenesis and tendon healing. They had some improvement in patient-reported tennis elbow evaluation VAS scores. Another option, which I think is kind of interesting as well, and goes nicely with the pathophysiology that we understand, but in my opinion, probably a little bit high risk, is to do actually transcatheter arterial embolization of abnormal vessels. This was done by interventional radiologists in patients who had over 6 months of symptoms, over 3 months of failed conservative therapy. They had improvement in all outcome measures that were assessed, and they did pre-intervention and post-intervention MRIs. This is the quick dash, but I think most interestingly, the angiogram on the top left is a normal angiogram around the elbow. The bottom left demonstrates that kind of diseased, vessels that are seen in patients with lateral epicondylitis. It almost looks like, I described it as like looking like moss kind of coming off of roots. In the middle, A and C also demonstrate patients with that abnormal vessel growth, and the kind of column on the right are the same patients as in the middle, just with the post-embolization. So I think that's an interesting thing to consider, and I do wonder, when we're addressing this surgically, if we're just cauterizing some of these vessels, then that could be causing some of the improvement. I think the downside to this is that, if you bring a patient in to get an embolization type procedure, what do you do if the angiogram is normal? There's also the option of, fat-derived mesenchymal stem cells. They've been used in a lot of other options, and that kind of, to me, falls in the regenerative medicine field. But there's at least one study that suggests that there's some benefit. It's more of a series, and it may be something that your patients start to ask you about if this is a part of your practice already using these, fat-derived mesenchymal stem cells. You could consider it. And again, these patients had improvements in their VAS scores and quick dash scores over time. Finally, something that I had not heard of before, looking at kind of new and evolving techniques, is to use neuromodulation. Essentially, they describe that patients with lateral epicondylitis often have atypical radial nerve cross-sectional area in the general vicinity. They actually will put an acupuncture needle immediately adjacent to the nerve all the way up to the epineurium, and then stimulate the area for about 90 seconds. And they argued that patients had, or they demonstrated that patients had improved patient-reported tennis elbow scores, and there was actually also some improvement in the cross-sectional area of the nerve and their pain scores. I think one of the newer things to consider, which I think is becoming more popular in the hand societies, is the concept and principle of denervation. And I would say that some of the proponents of the, open surgery still would argue that the sham surgery probably accomplished this denervation, and that's why it was successful. Where essentially, patients had denervation of the posterior branches of the posterior cutaneous nerve of the forearm. I think important things here in the series that Dr. Dellon had described is that all of his patients had, tried and failed 6 months of symptoms and non-operative measures. He also did a pre-surgical block to the posterior branch of the posterior cutaneous nerve of the forearm, and he, considered a positive response to be a 5-point VAS decrease. Most patients had improvement in pain and grip strength. He said 5 failures were in his series. 4 of them he attributed to radial tunnel, and 3 of them improved after radial tunnel decompression. These are some of the diagrams from his study. On the bottom right is a cadaver, the bottom left is a patient, and now the bottom right is actually an intraoperative view. The loop is around the posterior cutaneous nerve of the forearm, the vessel loop, and those are the posterior branches that you can see the piece of Esmarcher microsurgical field kind of underneath that he resected and buried in the triceps. I think it's really important when you're taking care of these patients to really inquire about the specifics of antecedent therapy. I found in my experience that a lot of patients don't have ideal or appropriate antecedent therapy, and it's really important to take the time and understand what they've gone through. There's nothing that frustrates patients more who feel like they've already failed therapy than being referred to therapy. So I think you got to understand certainly where they're coming from, what they've done, and you owe it to them and yourself to kind of explain why what you're doing is different. It's really important to preach patience, both for yourself and the person you're taking care of. I think that the natural course shows that most of these patients do get better up to a year. Some people will operate at 6 months. I tend to make patients wait a little bit longer just because of the natural history of this pathology. And then the other thing I think it's really important, and our hand therapy colleagues I'm sure we'll talk about, is to think about the kinetic chain. If people have a stiff shoulder or a frozen shoulder, it changes the way they use their elbow and the rest of their upper extremity, and that may be a big part of why they're kind of having this overuse type of phenomenon. So looking at the shoulder and the shoulder girdle becomes an important part of this. And the last thing is when everything works a little, do we really understand this as well as we need to? The good news is that most stuff kind of gets better. And I'll make a shout out to one of my mentors, Dr. Stern. It's really important to remember the power of hattage, which is essentially described as waving a hat over a patient and just letting time kind of get them better. It's really kind of describing the placebo effect, and I would strongly encourage it in this patient population. And then one last thing, that I think it probably falls more into the type of stuff that Dave Ring talks about, really, understanding the patients who are not getting better. This was a study that was done in Korea, but, they found that patients who, had better coping, were more positive in terms of the way they described and discussed their pathology, and whether or not they sought additional treatment, where they were tended to be kind of more negative thinking and negative phrasing. And it's really important to try and spend whatever time you can and leverage that with the patient. And I'm sure the therapists here do that quite a bit as well on our behalf, since we don't get as much time as maybe we would like. To kind of help try and reframe things. And I think that really can go a long way in taking care of these patients. All right.
That was fantastic. Well, thank you. Any questions that you want to put out there we can discuss? This is certainly a very tough and challenging subject. Any questions for Keith? Well, you can put them on the chat, and then we'll see if we can get to some of these at the end if we have time. All right, we're going to have Mary Barnes, occupational therapist, is going to tell us how to manage these patients with therapy. Mary, it's all yours.
Okay. Share. Okay. Sorry, I'm struggling a little bit.
Slideshow up on
Okay,
top.
this is on top of it. Okay. Sorry, things are stacking up. So what's new in the treatment of tendinopathies? Well, it seems like every day there's a new treatment that we read about. But what isn't new is that there's little consensus or evidence on what the best treatment is, especially for lateral elbow tendinopathy. And lack of effective treatments leave the patient and the provider vulnerable to unconventional interventions. In fact, there was a study that showed that over 50% of the ortho CEU courses taught interventions that are not evidence-based. But what is new and what's really great is more and more clinical practice guidelines are becoming available. And what our challenge is that we need to identify the right amount of therapy for the patient who's in front of us, the right amount of time for the right amount of time at the right stage, and also when it's time to refer to someone else. And again, as everyone has said, keep in mind that many tendinopathies are self-limiting and likely to improve with little or no treatment. More and more studies are showing that providers really aren't using evidence-based medicine. And that's the great thing about clinical practice guidelines is that they use synthesized and pre-appraised literature, and it saves us time. And some of the barriers to finding the right treatment, Many times there are too few studies, especially for overuse syndromes. And on the other hand, many times there are too many studies. There are poor quality studies, conflicting studies, um, uh, inconclusive results, and also they're nuanced. So many are nuanced. And I don't know about you, but I want to know if I should use a counterforce brace for my patient with lateral epicondylitis. I want to know yes or no, but the truth is it's more nuanced, and we just have to look at that individual patient. So clinical practice guidelines don't substitute for using good clinical reasoning and clinical judgment. And so when you're considering using some of these interventions that have weaker evidence, some questions to ask yourself. One is, of course, is it potentially harmful? Another, is it expensive? Is it expensive for the patient? And also, is it expensive for the system? Dry needling is not covered by very many insurances, and we're asking people to pay anywhere from $25 to $50 up front for needling. Iontophoresis, weak evidence, and most insurances aren't covering it, but the ones that are, it's got a pretty high ticket price to it. Heat, really little to no evidence, but it's free. And while we put heat on someone, we can do education. Taping takes less than 60 seconds. It's basically free. And although there's little to no evidence, it definitely provides visual and sensory and social input for the patient for 2 or 3 days. So why not try it? I think another question that we need to ask is, are we devoting so much time to interventions with weak evidence that we're neglecting to provide evidence with strong treatments with strong evidence? And many times, the patients expect some of these unconventional treatments. They've heard of dry needling, and they want cupping, and they love physical agent modalities. So sometimes we have to do things with weaker evidence for a short amount of time to get buy-in for the other treatments. And the other question I think to ask is, are we forthcoming about the evidence for these treatments, or are we selling snake oil? And if you asked any therapist, no therapist would ever say that they are providing snake oil. Every therapist believes that their go-to treatment is a valid and effective treatment. And the truth is that we're all biased. We are evolutionarily engineered to give more value to things that confirm our deeply held beliefs, and to dismiss things that challenge that. And we need to remember that just the natural course, and we need to remember the placebo effect, and be careful about misattributions. And these are the things that clinical practice guidelines do, is they give us, they help us challenge our biases. And again, there aren't a lot of good studies. Most of the studies are on exercise and education orthotics. There are fewer studies on functional, activity-based, and occupation-based treatments, and those treatments are really valuable. We need to see more studies. So trigger finger, the consensus on the literature is that the best treatment is mobilization with a splint and a steroid injection. And the first study compared the steroid injection alone, splint alone, and a combination of splint and steroid injection, and they found no difference at 1 year. So their recommendation was to start with the splint because, again, it's a lesser intervention. Another study out of Canada compared 3 physical therapy intervention visits. They started with that, and again, it's 3 visits, not 3 visits, not 3 times weekly for 3 months, but just 3 visits. And again, they did range of motion. Most people with trigger finger don't present with tightness. Some people do present with stiffness, and we need to see them a little bit and get full passive motion. So they started with 3 visits for range of motion education, again, the orthosis, and they found that 22% resolved with PT alone. If they didn't, they were referred for an injection, and 48% resolved, and only 12% were referred on for therapy. Here's another study a conflicting study that says there's very little evidence for any kind of conservative treatment for trigger finger. Again, very little evidence for physical agent modalities for trigger finger. Again, unless you're seeing them for stiffness, they really don't need ongoing therapy. A lot of articles on which orthosis to use, which joint to immobilize. And my go-to is I always start with the MP. The advantage of starting with the MP is that because the lumbricals isn't a quadriga muscle, they can still have full active range of motion in the adjacent fingers and the other joints. So I'll hold the MP in extension, have them make a fist 10 times. If they don't trigger, that's my go-to splint. This one's a custom splint, so it's a little more expensive. If that doesn't work, then I go to the PIP. The reason I do the PIP second is because you do get a little bit of blockage of the profundus. And so it's really hard to completely flex the other digits. And it's in the way a little bit more. The advantage is these are just the ovalate splints. They're very inexpensive. And if someone's going to sleep in it, really doesn't matter. There are some articles on studies on whether the relative motion splint is an effective splint for trigger finger. So if you want to know if it's an effective treatment for trigger finger for your patient, it's really simple. You just do the pencil test. Have them make a fist 10 times. If they don't trigger, then the relative motion splint is a good option. Again, for de Quervain veins, the preponderance of evidence is that an injection and a splint is all the treatment they need. They don't need ongoing therapy. In fact, the evidence shows that there's an uptick in the usage of hand therapy, but not necessarily in outcomes. And so we really need to think about how much we treat these people. And I would argue for de Quervain veins that a good custom thumb spica splint, forearm-based thumb spica splint with the CMC in a functional position of palm or abduction, DIP-free, and forearm-based, and the hard thermoplastic can protect the first dorsal compartment. So I saved the worst for last, hoping that I would run out of time before I had to talk about it. I think something interesting that one of you guys mentioned before was that we see about 14% of plastic surgeons and orthopedic surgeons get lateral epicondylitis. And so a lot of people listening to this, including myself, have been on both sides of the table, the treatment table on this, and it's a pretty frustrating thing to treat. The great thing about lateral epicondylitis is we have great clinical practice guidelines. And this is just a wonderful resource. It's published in the Journal of Orthopedic and Sports Physical Therapy. It's open access, 10 years in the making. It's 111 pages long, but the summary starts on page 2. There's a decision tree on page 44. And at the end, there's tables that you can click on almost every intervention, and they'll pop up all the evidence for each intervention. And again, it encourages you to look at irritability levels, and you're going to treat a patient differently who's at a heightened state of irritability, and maybe someone who works full time versus someone who has occasional pain when they play pickleball. I think it's something important, again, to remember is that there's no body of literature that strongly identified one specific treatment for lateral epicondylitis. And again, that makes us vulnerable, I think, to more unconventional ones. But we shouldn't be afraid to try things, and particularly if there's no harm, and see if they work. Another great article that I would refer you to is this article, and it compares tissue pathology and tendon function to ergonomics, and just a really, really good resource. And also there are resources like the National Institute for Occupational Health and Safety website and the U.S. Bureau of Labor and Statistics website, and they have such great information that's diagnostic specific and talks about safe ranges of elbow motion for different activities. And so you don't have to reinvent the wheel. There's a lot out there, and you may want to go to those websites now while they're still there, while they're still available. But again, I just say in conclusion that we have to use our clinical judgment informed by clinical practice guidelines, and again, to treat the patient who's in front of you. So thank you.
Thank you very much, Mary. That was a great review. Okay, do we have any questions out there that anyone wants to bring up? We have just a couple of minutes. We can maybe share some questions. Don, sometimes I think of a trigger finger, I think of a spectrum. And it all depends on where you catch the patient in that spectrum. If you catch them with the fingers locked down in the palm, or is it just a little inflammation and they're kind of on the other end of the spectrum? So I think some of that kind of relates on to where you find the patient. Do you find that to be a reasonable clinical,
Yeah.
practical way of looking at this sort of thing?
Totally. I think the one where you're really in trouble is when they come in looking like that.
Yes.
I mean, you got to do something to them, right? You can't leave them with the PIP flexed. So in my books, that person gets a steroid shot, but I'm putting them on the list like for as soon as I can get them in, and I'm going to operate on them because you can't leave that. But everybody else is all about how much does it bug you? And
Sure.
it's like I said in that consultation, people don't come to us because they're looking for surgery. They're come to us because they don't want to screw up their hand. And a lot of them, you tell them, you know what, if this doesn't bother you that much, and if you change your mind and you want surgery, I'll do it tomorrow. Like you go home and discuss this with your wife tonight, and you're thinking, oh man, you know what, I don't want to wait. Fine. Hey, I like making money, and I make a joke out of it, because I do. I like operating. It's fun, right? Why
Sure,
wouldn't I?
sure. Okay. Um, just on the same subject, have you had patients that have had the, encroached on the A2 pulley and they come in with bowstring after a trigger finger release?
I've never had a bowstring trigger.
You never had that problem?
No,
Okay.
I've seen it though, from elsewhere general, and I think it was tincture, lots of steroid shots and pretty aggressive surgery.
I see.
But bowstring is not something I see very often. Have you seen a lot of it?
Well, I haven't seen them, but I've had some patients in my career, and it's a tough problem to treat. And in fact, we actually talked about that at the academy meeting that we had recently. That was kind of interesting. Um, I remember with regards to lateral epicondylitis, the old Nerschel procedure. Remember that one, where you would actually repair the brevis, and in the society meeting that we actually had Dr. Nerschel. We had this forum that's called it's the retraction forum. So basically people that we found that their papers that they published in the past and their treatments that they had in the past were really not that going to be that useful. So you had the original author get up in front of the members and actually the journal of retraction, so to speak. It was a forum. It was very interesting, and he had a procedure where he would repair the micro tears in the extensor mechanism, and everyone would get in there and they would just see a lot of moon dust or some gristly material, and there was nothing there to repair. So he presented in front of the society members and basically said, I have to retract a lot of what I've written about in the past. And we kind of joked about it a little bit, but it was one of those things because we would get in there with these patients and not really find much to repair. And we felt that some of the improvement that they had in lateral epicondylitis was due to denervation, or maybe something else, or maybe in causing some inflammatory response to the surgery that caused help them resolve their problem. So it's very interesting. I think with all the literature that's out there and all the conflicting information, I think there's still a lot of work that we have to do in this area. Any other thoughts?
I think it becomes challenging because you have a lot of different people treating the same problem. They tend to have different standards, different approaches. I mean, when I saw that like IR was, doing things, I mean, they have, I'm sure, a totally different experience with musculoskeletal exams and, a totally different philosophy. So it's a common problem, so everyone's going to see it, but, it's almost like information overload, when you have so many different approaches and techniques and it's not standardized well.
I do remember one experience on clinical guidelines. We were trying to come up with some guidelines for distal radius fractures with the academy. And, we spent about a month and a half on that committee, and we really didn't come up with any real definitive, guidelines, which was a little kind of interesting. But sometimes the guidelines, you have to be careful with what you see and what's practical and what you can work with. Any other thoughts that anyone may have, regarding these excellent thoughts, lectures we've had tonight? Okay, but I think we're running out of time. What do you think, Sanu?
Yeah, Miguel, thank you so much. So I'd like to thank our speakers for their great talks on wrist and elbow tendinopathies. This is the first in our new update webinar series for the American Association for Hand Surgery. So thank you for joining us, and to our audience, we appreciate you spending your night with us, and we hope you'll join us for our upcoming webinars each month, and they can be found on the AHS website at handsurgery.org. Have a good night, everyone.
Thank you, everyone. Have a good night. Okay.
Thank you.